Good afternoon. I am Dr. Deependra, and I am the presenting author.
Okay.
I'll be discussing surgical technique for macular holes associated with epiretinal membranes and its correlation with the closure patterns. I think there are two relevant literature I'll just briefly show. I think this one actually speaks about poor results and unfavorable, closure pattern in this subset of macular holes, although there are few reports challenging this. And this one actually speaks about that if you try to peel ERM, almost 60% of times you will end up peeling ILM also along with it. And this has influence on our surgical technique for this particular category of macular holes. So we decided let's analyze our own results and see what happens when we use different surgical techniques for macular holes associated with epiretinal membranes. And of course, the cases having good videos, pre-op OCT scans, clinical data were chosen. Surgery was fairly uniform for all these cases. 25-gauge surgery, SF6 was used for 90% of these patients. We used Rossi's updated classification to grade post-op closures. And we excluded all those cases which have a confounding factor which can influence closure patterns. So just to show that we could find three different types of techniques which were used for these cases. This was one where we would peel everything, ERM and ILM, and just not use any kind of flap, just like we used to do in pre-flap days. So this was technique number one. The second one was where again we are peeling both ERM and ILM together. You can see the patchy staining which tells us that there is an ERM, and we are using this both ERM and ILM as a flap, as a scaffold. And the third technique which we were using was we were trying to remove the ERM and use only pure ILM as a flap. And this technique is more challenging, but we could do it in certain number of eyes, as I will show in the results. So these were three different techniques used to manage these 22 eyes. And this is all demography. You can see MLD of 200 microns and 728 basal diameter. So they were heterogeneous group of macular holes. And as far as anatomical results go, we could get closure in 95% eyes. Only one eye didn't close. Visual acuity improved from 0.8 to 0.4 in this whole group. If we stratify them by different peeling techniques, we could do complete ILM peeling with no flap in 8 eyes, and we used some kind of flap in 14 eyes. And when we tried to compare the visual outcome, it was fairly comparable between both groups, complete peeling and flap groups. There was no statistical significant difference in change in visual acuity between these two groups. But the most important point of interest was type of closure. Now, where we didn't use any flap, we got type 1 closure in 100% eyes. But when we were using any kind of flap, the type 1 closure we could get only in 53% eyes. And when we tried to do further analysis, what we found was when we were using ERM flaps, almost 71% eyes ended up getting a type 2 unfavorable closure. And if we were using pure ILM flaps, 12.5% eyes only got type 2 closure. So ERM flaps were found to be much more notorious in getting an unfavorable closure. And another important learning what we had from this study is 63% of eyes, whenever we tried to peel ERM, we ended up getting no ILM left. So that means we had only two options. Either we use that ERM as a flap, or we just go ahead with no flap technique. So this was again which we learned from this study. I'll just show some results. This was complete peeling, no flap. You can see good type 1 closure where ERM flap was used. Again, type 2 closure, ERM flap showing type 2 closure, inverted ERM flap showing type 2 closure, plain ILM flap giving a very good type A, type 1 closure. Again, here even after using a pure ILM flap, we got a reasonably good type 1 closure. And again, type 2 closure whenever, this was even in ILM flap group, we got this. So I think The main conclusion which came out from our study was that ERM as a flap should be avoided whenever you have this macular hole with ERM. Thank you.
Thank you, Dr. Deependra. Any questions from the audience?
Dr. Deependra, I wanted to ask you, how did you randomize your cases, that which technique you're going to apply in which case?
It was a retrospective study. So the choice of technique was surgeon's decision, and most of the times on-table decision. It was not even a pre-operative decision. So there is a bias. Yeah.
Usually a
The
smaller
hole size was very well balanced between all the groups. When we did this analysis, baseline characteristics, size of holes, all other parameters were very well balanced between both groups.
But then there would be a this thing, no? Like if you with a no flap technique, usually it would be in cases where there would be a smaller hole as compared to a type 2.
We didn't have that option. When you lose ILM, when you are peeling the ERM.
No, in those cases I understand, but the primary first two groups where there is no.
If I'm not allowed to go back, but the number of larger holes were equal in both the groups.
Okay.
So, thank you.
Yes.